Illinois Stories is brought to you by the Corporation for Public Broadcasting and by the support of viewers like you. Thank you.
Hello, welcome to Illinois Stories. I'm Mark McDonald in Springfield at what will become the Kindred Hospital of Springfield. It's located only about 2.5 blocks west of Memorial Medical Center. We asked the folks at Kindred if we could come in before they admit their first patient so we wouldn't be in the way of patient care, and to give you a look at Springfield's newest medical facility. Well, Dr. Sean Muldoon, you're the Chief Medical Officer for the hospitals of Kindred Healthcare.
That's correct.
There are 90 of them.
That's right.
And Springfield is soon to have its own Kindred Hospital. We're in the area here where most patients, or all patients, would be brought in, usually to this hospital by ambulance. Is
That's
that right?
correct.
Because why?
Almost all of the patients will come to a Kindred hospital from a short-term acute care hospital. We expect it will be largely from the community hospitals here in the Springfield area.
Mm-hmm. What makes a long-term acute care facility different than most other hospitals?
Well, there are, I would guess, 4 categories of healthcare centers that exist. The short-term acute care hospital, which everyone is familiar with, and then skilled nursing facilities, independent rehab facilities, and home care and hospices. Long-term acute care hospitals are part of those post-acute care settings that include SNFs and their rehab hospitals.
Now, what does SNF mean?
Skilled nursing facility.
Okay, good. Okay, so what you do is you're generally your patient comes in here, and this person is going to be here for more than a few days.
That's correct.
And it needs really sort of intense, not intensive, but intense care.
That's right. We are acute care hospitals by every standard: licensure, certification, and accreditation by the Joint Commission. Therefore, our standards are the same as a very large hospital. Where we are different is that we focus our care model on those small number of patients whose plan of care is going to take weeks or even a month or so. Not like the short-term acute care hospital where the average length of stay is 5 or 6 days.
Okay.
For us, it's more like 18, 25, 35, or even 40 days.
Okay. If you would, doctor, hit that button behind you so we can go into the area, and then we'll see where a patient goes from here.
This is the experience the patient would have when they come to our hospital.
Mm-hmm. Okay, the ambulance brings them in here.
The ambulance will back up to that apron. They'll be wheeled out here. The receiving nurse will greet them, get a handoff from the ambulance driver, and then they'll come through this corridor.
Okay.
Here we'll pass the physician's lounge where the physicians may be waiting, they may be doing some charting or some other thing. Around this corner, come to our elevators and go up to our patient care floors, which are floors 2 and 3.
Okay, and we might mention to our audience, the reason we wanted to be here before you opened is because once you get patients in here, we run into all kinds of privacy issues, and showing the hospital becomes very difficult.
It's really
nice
does.
for you to let us come in here before you open, because people get a chance to see the whole thing without all those other issues going on.
Right. Issues of security and privacy are really paramount in our minds as well as yours. And we are able to get many patients who are willing to tell their story, but to tell you the truth, when you're in a hospital under these circumstances, you're frankly not in the mood.
Yeah, I got you. Okay, let's go up and see where the patient comes in here, and we're going to go upstairs and see what the patient rooms area looks like. There it is. After you, doctor.
All right, we've just come up the elevator from the receiving area where a patient would come with their nurse team, and we'll make the turn into the high acuity unit.
Okay.
And you'll see in here we're doing some training. We're getting people used to things like our electronic medical record. We'll start with an electronic medical record. We've had that unit for since 1992. We're the first post-acute care company to go with an electronic health record. And here we are. We're in the patient care area. And
these people have been recently hired. They're in training now. These are nurses, technicians, people that'll be manning the floor.
That's correct.
Okay.
That's correct. They're learning a number of things. One is care processes, one is operational processes, and the third is the safety processes.
And when your hospital is full, you have 50 beds, so you'll have roughly 50 patients when the hospital's full.
That would be great.
Yeah, that would be great. Yeah. Okay. And this is the room that your normal patient would be admitted to.
This is the high acuity unit, so we would use these beds for those patients that are of even a little higher acuity than normal. Now, to the passerby, this might look like an intensive care unit equipment because, in fact, that's what it's equipped with. It has a mechanical ventilator for those patients who need a machine to do their breathing for them. There's a heart, blood pressure, and rhythm monitor there. People know that as cardiac monitoring or telemetry. We have an overhead rack and a patient lift because so many of our patients are quite heavy. And even the ones who are not real heavy, we do want to protect the ergonomics of our nursing staff.
So that helps them get in and out of bed, I guess. Is that what that's for?
That's right.
Seen. Okay, all right.
That unit would move over to above the patient. We would lower it. We would hook big wide straps underneath the patient and then either lift them up to as simple as change sheets, but then often to pick them up, move them over, and get them out of bed. One of the big differences for long-term acute care compared to short-term acute care is we like them out of bed. That's better for them. It helps them understand they're getting better from what is always a catastrophic illness for them, and does very good things for their circulation and physiology.
We've used the term acuity and acute a lot, and I know that people in the audience, like I am, thinking, okay, what kind of conditions or what kind of diseases are we talking about that most of your patients would be encountering?
Okay. I'm going to discuss it in two ways. One is category of illness, and then the other is severity of illness. On the severity side, because we are acute care hospitals, our patients have to have the identical severity that would warrant admission to a short-term hospital. So these are relatively sick people. We have acuity measures that intensive care units use, what we call an Apache score, and our patients' Apache scores are just a slight amount lower than an intensive care unit across the country. So this is not the patient that could go to a skilled nursing facility, a rehab center, much less home.
Okay, they need care, almost round-the-clock care.
Oh, yes, around the clock.
Round-the-clock care.
Hour to hour in some cases, particularly in the high obs unit. So they are stable more than those in an intensive care unit, where the true goal is to get them through the next hour. For our patients, they fluctuate more on a day-to-day basis when they're in the high acuity unit. When they're out on the floor, their improvement is measured every couple days.
How does that patient or the patient's doctor know when it's time to leave the short-term hospital and be referred here?
LTACs are not for everyone. And a matter of fact, they're actually for a very small number of patients. Probably about 1 or 2% of the patients coming out of short-term hospitals. But it's a very special population. And it's that population that did not behave the way other patients with those same conditions behave, meaning they didn't immediately respond, bad things happened to them, they had many organ systems that needed attention, and so they need a place to go for the long treatment plan. How people decide is a little bit variable, but my rule of thumb is when it's pretty clear that this is not a typical patient who's going to need a long time, and yet you have them reasonably well figured out, that's the time to think about a long-term acute care hospital. It tends to be somewhere between day 7 and about 14. And that is very long for a short-term acute care stay, because most of those folks are kind of in and out in 4 to 6 days.
And you might keep them here for how long?
We have a lot of flexibility there. Some stay a week, some stay a couple months. There is a certification requirement that for the Medicare patients, now this is only the Medicare patients, that at the end of the year we show to the government that on average those patients stay 25 days. But there'll be a lot that stay 15, a whole lot that stay 20 to 30, and then a few that are here 30, 40, even 50 days.
Well, doctor, thank you for the tour. We appreciate it.
Glad to do it.
Sherry Hendrickson, when patients' families or visitors come into the new hospital, this is where they'll be greeted by a receptionist, and this is the first place they'd come.
Correct.
Yeah.
This is the main entrance.
You know, everything is so brand new, and I think what surprises me is that in this day and age, you always hear about hospitals closing down, and I never hear about hospitals opening up.
That's true. Today
It's a rarity.
We do, but we are a special hospital, being a long-term acute care hospital. So we do provide a special service meeting a particular need within this community.
It's not only is it strange to hear about hospitals opening up, but yours is a relatively small 50-bed hospital.
Correct.
And there aren't really many of those around, are there?
No. No, most of hospitals that are 50 beds or less are in short-term acute cares, are critical access hospitals, or in the LTAC world, the long-term acute care hospitals, our hospitals run 50 to 60 beds mostly. That tends to be the average. There are smaller.
And your service area would be central and southern Illinois, I
Correct.
take it. And there's a similar hospital or a hospital that provides similar service to this up in Peoria.
Yes.
So
there is.
south of Peoria would be your market area.
That would be our market area out to Decatur and even possibly out to Champaign, that far out. We have hospitals in St. Louis, and patients from Springfield would have to go to St. Louis or to Chicago, Indianapolis to get long-term acute care.
So this is a really good centralized area for you
Absolutely.
that you're currently underserving, I guess is one way.
Absolutely.
Well, listen, take us back. Let's take a
Okay.
walk through here. It's very compact when you think about most hospitals. This is a very compact operation, but it's got everything.
Yes, we do. We're a full-service hospital. We have our own rehab department that will provide all three disciplines: physical therapy, occupational therapy, and speech therapy.
I'll tell you what, let's just take a little peek in there, because we're going to come back here and look at this and talk to one of your therapist people a little bit later. But let's just take a little peek in there. There's nothing in there now because, as you know, you haven't opened yet. But
Right.
this will be the rehab area, and there will be equipment in here of a variety of different kinds, and we'll talk about that as we go through it. Like I say, we're going to interview your rehab person. But it's interesting. It's nice to see. It's nice to see a brand new facility that hasn't even been used, hasn't even been filled up with equipment yet.
With shiny floors.
Nice shiny floors. You're also going to
Absolutely.
you'll have your imaging services.
We do imaging. We actually do all of our portable imaging, in which we have, this is our portable x-ray machine that we will take to the units to the patient floors. Then we have what's called a C-arm, and what we use that for is to watch patients as they swallow. We do what's called video swallows. We then digitally manage our films, send them to the radiologist for interpretation. And the nice thing about it is our radiologist can bring up the films wherever they are on their computer, as long as they have their password. So it's very functional.
Yeah.
And units have become so compact.
Yeah, it's amazing, isn't it?
It is.
And portable. You can just
Yes.
take them right up, down the hall into every room.
Absolutely.
You have a pharmacy here, and we're not going to go there because there are no pharmaceuticals on the shelves yet.
Right.
But you've got your own pharmacy. You really have everything that a hospital, a short-term hospital has.
do.
But you have maybe 1,000 fewer beds in some cases in some of the big hospitals.
In some
Yeah.
cases, it is 1,000 fewer beds.
Yeah.
And what makes it nice about having the 50 beds is it's being this small. Everyone knows each other. We are all just one big family taking care of patients. And we're all here for the same purpose.
You know, there's another issue I want to ask you about. Hospitals are in great competition. You know, if you live in Springfield, for instance, there's two major hospitals,
Yes.
and they're competing all the time.
Absolutely.
You see that in Decatur. You see that in a lot of cities. In your case, you're rather welcomed by the bigger hospitals because you provide a service that they need, don't you?
Oh, absolutely. Both Memorial and St. John's have been extremely supportive of are building this hospital. They have been instrumental in us obtaining our certificate of need from the state when we all started. And I have met with both hospitals. They just really cannot wait until we're fully operational. And we can help them decompress their ICU beds for patients that really need them.
Right, and for people that may not understand exactly, I mean, we've been talking about the services you provide, but maybe for somebody who has just tuned in, what happens is the people who are in ICU and are ready to leave the intensive care unit of one of the short-term hospitals, in many cases, there's a gap there of services for them, and the short-term hospitals need to move those people,
right,
because they have need for that intensive care space.
Absolutely.
This gives those patients a place to go.
Absolutely. This gives them another option. That because these are patients that are too sick to go out to a regular floor in the hospital, and we bring them here, we take care of them. We're used to that high acuity patient.
They can't go home.
No.
They can't go to a nursing, many of them not ready for a nursing home yet.
Absolutely.
And so really they need daily and sometimes hourly constant care.
Absolutely. They need the care, they need the daily visits from the physicians, all of that.
Yeah. Now there's one other thing I want to see before we go.
Okay.
I've never seen a brand new kitchen that's never even been cooked in.
Well, you have got to see our kitchen.
We got to see it. Come on, let's go. Okay, Sherry.
All right.
Now this is absolutely gleaming. Look at this.
Is this not gorgeous?
When was the last time you saw a stainless steel kitchen without even a touch of grease or butter or anything on it?
No spatters.
Wow. You guys are really ready to cook. Man alive.
We are just, we can't wait to fire up the kitchen.
I'll bet you can.
And start
Okay, I'm thinking,
patient trays.
50, if you're full, 50 beds, that's 3 meals, that's 150 meals, at least 150 meals a day, right?
Approximately. A lot of our patients don't eat, so it's an average.
So you need a big kitchen.
We need a big kitchen.
Yeah, and you got a big
feeding
kitchen.
Staff.
Sure.
And this will be the tray preparation area, so we can heat up plates and keep them warm in the bins till they get to the floor.
Excellent. Dr. Muldoon, we talked about some of the conditions that your patients have, and many of the patients that come into an acute care facility have wounds that need constant attention or won't heal, or both, I guess.
That's correct.
And so many of your patients would be in that position where they need daily care, or maybe even constant care for their wounds.
That's correct. In addition to the mechanically ventilated or pulmonary patient, the second largest group of patients we expect to have is the patients with wounds. They will come to us with wounds of multiple types of etiologies, either pressure wounds, vascular wounds, or surgical wounds, for the treatment and resolution of those. And we develop a very broad expertise on that. You know, for example, last year we had 300 or so of our wound care coordinators come into the company for 3.5 days of state-of-the-art policy and procedure, what's the best way to do things, and we called that a clinical impact symposium. And we've done the same thing a month ago with our respiratory care group. So 2 areas that we really pride ourselves in being the best.
I asked you to put together a couple of pictures for us, and you have up on the top left there. If you let me point it, that one there. What are those clinicians doing with that foot there? What's going on there?
Most wounds can heal when we treat the entire patient in terms of their nutrition, their circulation, and the like, with good standard nursing care. However, there's a subgroup that we need to apply fancy technology to, and there's a number of them out here. This is an example we call pulse lavage therapy. And that's where you take a wound that is full of dead tissue, secretions, bacteria, and the like, and you get the dead, unwanted stuff off by shooting jets of special liquids at it. And it sort of mechanically cleans, sanitizes, and improves the circulation of those areas. And with better circulation, less crud, if I may, in there, the wounds heal much more readily.
Mm-hmm. And below it, now we're looking at some kind of a monitor and device that's also doing some kind of, what job is that doing?
This device is called a negative pressure wound therapy device, which if you think about is when you have a wound that is actually a cavity, if we can put a vacuum on that wound volume and kind of suck it closed, and at the same time use a sponge or a piece of gauze that sort of rubs the surface and gets that dead tissue out of there, the bacteria, the exudative liquid things that then just kind of sucks it out of the wound through a tube into a canister. At the same time, it's covered with a surface that keeps infection from getting in there. Then for certain types of wounds, that will accelerate their healing.
And this patient may need to have that device on him or her for days at a time, I guess.
Yes. Yeah, every wound gets assessed individually. And again, most of them, standard good nursing care can do it, but when we need to apply technology, there are protocols that determine what wounds are likely to respond. And most of these, you need a trial of a week or so, and then you make the determination, is it helping? And if so, you keep going. If it's not helping, then you try something else.
Thanks. Well, Doug Witzig, you know, before a hospital opens, you know, there's not a lot of activity, but there is orientation, and that's what you're going through right now, right?
Yes.
You're going to be nurse supervisor here.
Yes, sir.
You've also, however, been a respiratory therapist.
Yes, sir.
In the past. So, knowing that many of your patients come with respiratory problems and need ventilator, you're going to be probably a valuable asset here.
I hope so.
Yeah?
Yeah.
You know, I've never really looked at a respirator or a ventilator like this. Show it to me.
All right. This is a basic ventilator, minus the tubes that come on it. There's two tubes that come out. One comes with the patient, one comes from the patient. One tube pushes air into the patient at a certain volume, certain pressure, and a certain oxygen level. We drop this down. This is the expiratory port.
Now, what does that mean?
This measures the outside, the air that gets exhaled from the patient that blows through here. There's some very sensitive veins in there. They can tell the volume, pressure, a whole bunch of things depending on what the setting's set at by the doctor on what he wants it to do. There's a whole bunch of bells and whistles that you can run through here just depending on what you want to monitor and what the patient's condition is. It can be anywhere from a basic ventilator. You can use it for just a CPAP mode where it just helps them breathe. Just depends on the situation, what you want to use it for.
In a hospital like this where you have this long-term acute care, many of these patients can't breathe on their own.
No.
And that's an absolute necessity.
Yes, it is.
How would this be attached? Would it be a mask? Would it be a tracheotomy tube? Or how would most patients be attached?
It depends on the patient situation. You can do a face mask ventilation where it's basically a mask that you see like when you're doing CPR, if you see them in an ambulance on the hospital shows, they put a mask over it, they'll strap it down. That's a face mask ventilation. They can do an ET tube, which is an endotracheal tube that goes in the throat. You'll see it sticking out of the mouth in some of the shows, or they can put it on a trach. It just depends on what you want to do, but you can do all three of them.
Depends on what their condition is and what their abilities are, I guess.
Yes.
So some of them, probably a mask wouldn't work because they actually need to have the air pumped into them, I guess.
Yeah, and some of it just might need the mask as a temporary relief from them for a couple days and they'll be off of it. If you need more intensive, then you put an endotracheal tube in. And if they already come to us, most of the time they'll already have a trach in if they've had an airway for a while. So then we'll try to wean them off as aggressively as we can and get them home as quick as possible.
Well, April Bogan, we're in the rehab area. You're the director of rehabilitation for the new hospital. And rehabilitation for patients at this hospital might be a little different than people are used to, say, for cardiac patients, because these patients are not in very healthy condition, are they?
Correct.
They need a lot of help.
They do.
Yeah. One of the interesting things you're going to have here is back in that nook back there, you're going to have a kitchen so that people can learn how to take care of themselves on their own. What's going to be back there?
Exactly. Back in this area, what we're going to have is a refrigerator and a stove. And basically what we're going to do is assimilate a home kitchen. so that these patients can learn to cook again. They can learn to do the simple tasks of opening the refrigerator, things that they have to do every day when they get home, because that's what we're trying to do, is promote independence within their home. So when they go home, we know that they are safe to be able to do all those tasks on their own and be back in their family and their home setting, which is where they want to be ultimately anyway.
And you actually have an occupational therapist that would help them in that. You also have physical therapists that would work in the same area.
Correct.
What would that person be doing?
Basically, the physical therapist, what they're going to do is, if you can imagine, there'll be a mat here. And what we're going to do is work on their range of motion, being able to move their legs again, being able to use their muscles to be able to get out of the bed, to be able to stand up and ultimately walk like you and I do. Right now, they're so weak that they're not able to do those things. The basic things that sometimes we take for granted, they can't do, and they want to do it so badly. So that's why we're here to try to help them to do that.
A lot of these patients will need to learn to communicate again too, won't they?
Exactly.
And so you have speech therapists.
Correct. We have a speech language pathologist who will be here that will help them with their speaking, help them with their swallowing in conjunction with the occupational therapist, and basically to give an overall picture of helping that person get back to do what you and I do every day.
Thanks, April.
No problem. Thank you.
The certification and demonstration process begins in December, but by next fall, Kindred expects to be treating patients and be fully open for business. With another Illinois story on North Walnut in Springfield, I'm Mark McDonald. Thanks for watching.
Illinois Stories is brought to you by the Corporation for Public Broadcasting and by the support of viewers like you. Thank you. For a DVD copy of the program you've just seen, send $19.95 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.